Okay, my name is Robert Pollock, and I'm doing my patient history reflection. So, over the past week or so, we've been doing patient histories to get used to the orthopedic evaluation process. In the past week or so, I've had 3 patients come in. One of them was a mock, and that was just to make sure that my preceptor was comfortable with me taking information from someone. The other 2 were actual patients. The 2 that I dealt with that were actual patients were probably my better ones. The first one, I wasn't very patient-centered. I didn't ask age, name, what sport you played, or anything. It wasn't the best work possible. But the last 2, the first one was a foot injury, and I asked her name, her age, if she's had anything like that before. Trying to be super friendly so that they can feel like they're open, and I'm not going to judge them if it's like not a severe injury, and treating it like it is a severe injury. And then the second one was a football player who came in after a couple days and had knee pain. Didn't really think much of it, but when we started doing history and watched gait and stuff, noticed posterior translation of the tibia, which was very concerning for us. Again, trying to keep that one. He was very muscle guarded, so trying to keep him from compensating was really hard, and trying to get him to relax was also really hard. So what I tried to do with him was talk about things other than what happened, like this injury. So for instance, I talked to him about how school was going and if he had trouble walking, if they'd done anything, stuff like that. So talking first about approach, I felt like my approach was really to all injuries is just it's serious until we start ruling out things or ruling in things. So when I'm doing the history, I just try and, regardless of if it's a middle schooler or a high schooler, I try and say that, this could be a serious injury and we need to treat it as such until we start, my preceptor starts doing special tests and active range, resistive range, all that stuff. So the second thing I want to talk about is how my history questions would guide the evaluation process. So obviously I had a lot of lower extremity injuries, the first one. So how it guided me was if they remembered a certain time that was very painful for them, it kind of ruled in like ACL, stuff like that when it was the knee injury, the guy with the knee injury. Trying to see if it was a macro trauma versus a micro trauma. And if it was micro trauma, like if they've been doing activities to help them, like icing and using ibuprofen or stretching simple injuries. However, like when you start asking the questions, so like, when did it first happen and is this your first injury? Like, that's when you kind of cast a huge net when they come in. You think it could be multiple things in the knee, and then you start using those questions and trying to rule out, rule in before, so you're making your differential diagnosis before you start testing to see if it's actually the pathology. The next thing I want to talk about is things that I left out that I really didn't think of until my preceptor, Caroline, we debriefed. That would be if it's their first injury. It was very common in the one middle schooler I got that it was her first injury and she really didn't know how to deal with it, and she didn't know like what sensations she was feeling. So for example, we asked, what kind of pain is it? She said, I don't really know. It hurts sometimes, but it's not hurting all the time. So we said, well, does it feel like, so describing the pain really helped for her. So we were like, well, does it feel like someone took a knife and stabbed you? Or does it feel like it's just like an ache, it's sore? And for her, it was just soreness, and it was very helpful to explain especially with a first-time injury, the sensations that you'll feel or are possibly feeling. The other thing I wish I would have asked more about was the activities of daily living. So in both cases, more so with the football player with a knee injury, I wished I would have asked if he'd been sleeping. The answer was no, because my preceptor asked it, but if I would have asked that, it could have been more a way to get patient-centered, and it would have shown him that like I care about him more than just as an athlete, I care about him as a person. And if he's not sleeping, then he's more irritable, he's more likely to not do things that we want him to do that will help him in the long run. If he doesn't sleep, he's not going to do anything that's going to be helpful for him. And then finally, I'd like to have asked about like family history. I asked about if they've had any injuries, but for example, the volleyball girl, she said, yeah, my mom has really bad flat feet. Pretty much my entire family does. So I wish in that case when we were doing a foot eval that I would have asked like, do you know of any do you have flat feet? Does it kind of run in your family? Do you know? Because again, with a first-time injury, they don't know all the time like what they want us to hear. So they say what they're thinking, but in most cases, it's not. It's like it just hurts. Well, we need a little more information than that. So trying to guide that. Finally, like the things that worked best, like question-wise for me, were how did this injury happen? Especially with the knee injury, it was a macro injury, and with him getting that mechanism of injury, so he had taken a helmet to the anterior tibia. Getting that mechanism of injury helped get a clear picture of like what the differential diagnosis might be, and that was really a good way to understand like, okay, it's probably not this or it's this, ruling things in and out before touching the patient. Another question that I really liked was getting their name and age, especially over at my clinical site. We have a lot of athletes that come in with Oxlauters, so knowing, okay, it's knee pain, but it's centralized and you've been diagnosed with like growing pains, that would be a good way to understand, okay, maybe it's this, maybe it's not as, we don't need to jump straight to like, it could be patellar tendon or something more serious. It could be something like Oxlauters, and we can do simple things to manipulate it. Also, just getting their name shows like I actually care about you, other than just your number 23 or 34 or whatever your number is. It gets more of a patient-centered reaction to it, so I can create a bond between us. Another thing that I liked was like not so much asking question-wise, but looking, especially with the football player. When we noticed his gait, we noticed posterior translation in the tibia when he was walking. So looking at things that you wouldn't necessarily ask the question, but looking at gait, looking at if they're compensating, using other muscles to make the motion, or if they're holding their wrist and can't like let go of it. Just simple indicators that it could be something a lot worse. And then finally, my last thing that I liked that I asked was about treatment. So in both cases, they had been icing and using NSAIDs. So for me, that shows that there's probably something going on there, more than what normally is. And it also helps to see, okay, that didn't work, what else can we do? And developing a treatment plan and going through ligamentous tests to see, okay, maybe they took a muscle relaxer, so MMTs aren't going to work or ligamentous tests aren't going to be effective. So for that, I thought their at-home treatment is really good to know. And that is pretty much it for my patient history. I look forward to clinically studying and doing the orthopedic eval further.